All right, what did everyone think of the test? Not bad, fair. Okay, yeah. It's really. Can you have a good test? Really, probably not, but it's okay. I will review the stats on it afterwards. If there's any high misses, I'll address those. Sometimes there's a miss key. Sometimes there's a valid point that it's a bad question. Who knows? I'll check it out and see what the stats bear out. I don't foresee that, but we'll check it out. And then any high misses, I'll usually put an announcement out saying, hey, this is the concept. Maybe some people need to go back and review, things like that. Again, remember the last test is going to be 50 questions and it is cumulative, so it's going to cover all this stuff again. So you can't just forget it all. You need to make sure you keep this in your mind because, again, this is going to be used all throughout Pharm 1 and 2. So you need to know all of these things here, okay? Anyway, so any questions before I get started? Not at all. Everyone's a little brain drained already. That's why I hate doing like lectures right after a test, but it is what it is, right? So anyway, so getting into the kinetics. Oh yes, ma'am.
I have one.
Sure.
About aspirin being antagonist, antagonist. So it completely inhibits the cyclooxygenase compared to ibuprofen, but then its effect is more on the antiplatelet. But when it comes to pain, would that be more effective with pain?
Not necessarily. So you end up seeing that as an example, your platelets once they're made, if you go back to your the actual morphology of those cells there. Remember, platelets don't have a nucleus, right? So once they're made, they can't really make any more cyclooxygenase versus something like a red blood cell or say like a neutrophil or something like that. So in terms of pain, you don't really see that long-lasting sort of effect from that because those cells can produce more cyclooxygenase if it needs to, right? Even though it's an irreversible inhibition. Yeah, it's a good point. No one's ever actually brought that up before. You expect, okay, well, aspirin has this really long-acting pain relief, but it really doesn't have that clinically. You tend to see that it works just like an ibuprofen would or something like that. Yeah. It's a good point, though. Any other questions? Okay, so getting into the pharmacokinetics, remember this is, again, what the body is doing to the drug. So how are we actually processing things, how's it being distributed, absorbed, etc. We'll also get into talking about things like loading doses, we'll talk about steady states, and we'll talk about toxicities and how those manifest. I probably won't be able to get to all of this today, but we'll see what we can get through in the hour that we have. So again, if you remember, when we were talking about this previously, essentially what happens is once you give a dose, however you give it, whatever route you tend to administer it, you're going to find that the drug will be absorbed. And this absorption process is the first part of the kinetics, right? So we talk about the A, D, M, and E. So that's absorption, distribution, metabolism, and excretion. Remember, some of that drug is going to partition out into the tissues. It's going to get to its site of action where it's going to have its clinical effect. Those are the pharmacodynamics we're going to focus on more in Pharm 1 and 2. But you're going to see that some of this is going to be some drug is going to go to the liver. What happens in the liver, do you think? A lot of metabolism happens within the liver, right? We talked about the first pass effect a little bit already. We're going to get more into details on that. Some drug, yeah, remember prodrugs, those are actually inactive until they hit the liver and they get activated, right? And then you'll finally find that where do most drugs do you think get eliminated from the body at? And yeah, the kidneys are a big site. Anyone can think of any other sites? The bile is actually one, right? So it'll get processed through the liver and then get sent out through the bile. So that's actually another way you'll find some drugs actually get eliminated in the feces, right? Through the biliary tract into the GI tract. So anyway, let's talk about absorption first. So how do drugs actually get into the body? It'd be easy if we can give every single drug IV because you don't have to worry about absorption. It's right there in the vein. But clinically, that's not super convenient, especially when you think about getting IV sticks and infections and all kinds of other issues with it. Let's look at the absorption here. So anyone remember back from their kind of first biology classes talking about passive diffusion and semi-permeable membranes? I hope you remembered all of that because we're going to cover it again today, right? So you don't actually have to remember all of it, but I will cover the salient points here for our purposes. So permeation, right, is just the process of things partitioning through semi-permeable membranes, and typically it goes from areas of high concentration to areas of low concentration, right? This is a passive process that requires no energy whatsoever. Two things we'll talk about are one going to be aqueous diffusion. Again, this is a passive process, again, going to be driven by the concentration gradient. One of the big things that's more important for our purposes in terms of absorption is going to be lipid diffusion, right? So how easy is it for a drug to cross lipid membranes? Now, where do you find these lipid membranes at? Yeah, the lipid bilayer of all cells, right? So essentially, if you want to get something absorbed from the GI tract, it's going to have to make it through several of these membranes to get into the central circulation, right? So if you have something that is particularly lipophilic, do you think it's going to make it easier or harder? It's going to be pretty easy to get through, and we'll cover those details there. If it's particularly hydrophilic, you're going to find it's going to be a little bit harder as the case may be, okay? That's also going to be really important in terms of distribution, as we're going to see in just a few slides here, okay? But remember, there's a lot of lipid membranes that drugs have to get through in order to make it to its site of action. So the easier it's going to be able to get through that, and we'll look at the factors that affect that, the easier it's going to be to get to that site. So again, there are other processes as well that can help this out, because not every drug may be able to get through those lipid membranes. How do we get some drugs through? Well, we have things like carrier-mediated diffusion, right? So you can have things that maybe can't pass through on its own. Sometimes we'll have transport carriers and proteins that will help this out. In some cases, this is actually going to be an active process that requires ATP, right? ATP is the main energy currency of our cells. By utilizing some of this, it's able to drive some of these drugs across. So some drugs that would not be able to bypass that membrane on its own can get across. And also, the other thing here is, does it always have to go from areas of high to low concentration? No, we can actually go the opposite direction when you have energy involved here, right? If it's passive diffusion, there's no energy. It's always going to go from high to low. This is the opposite case here, where you can actually drive it from low to high, as the case may be. Have you covered any like cardiac physiology yet? Have you talked about like sodium potassium pumps? Ever heard of like action potentials and all of that? So the very good example that I'll probably talk about probably ad nauseum, take your Zofran if you need to, is going to be the sodium potassium pump and how important that is for maintaining the normal electronegativity of these membranes. But it is one thing that drives ions, particularly sodium and potassium, against their concentration gradients. But it's an active process and it requires energy for that to occur. Don't worry about that. We'll get to that much later on when we get into specific examples. Anyway, so just know that there's active processes available. There's also going to be passive processes. Just know which ones require energy and which ones don't, essentially. Now, again, I'm mainly going to kind of be talking about aqueous diffusion, but this is the same thing is going to be applying to the lipid diffusion as well, right? It's just a matter of how lipophilic things are to get through those membranes, but all the other factors are going to be pretty much the same here. And again, we have a lot of large aqueous compartments within the body, right? So we have our central blood supply, which is an aqueous compartment. We have the extracellular fluid, right? We have intracellular fluid. We have interstitial fluid, right? So you have a lot of different fluid compartments that drugs can be partitioning through. It's important. I'm sorry? That interstitial, like kind of between the cells, right? So there's fluid even there, but in between the cells. Yeah, exactly. So, and again, when we talk about things like extracellular versus intracellular fluids, we'll talk about that quite a bit because that's really important for things like fluid balance, right? So if you have a patient who's dehydrated, how do I get fluid back into those cells? Or if someone is overhydrated, maybe they have edema, how do we get that out? And that's really important to talk about those, and we'll get into all that later on. But has anyone ever heard of Fick's law? Okay, you probably have heard of it at one point, but you repressed those memories so long ago, or it's so dusty, but we'll dust that off here for you in just a second. But anyway, so you're going to find here that Fick's law is going to be really important in terms of determining how we're going to be getting things through these membranes here, okay? So don't get too worried about the math here. It looks more complicated than it is. A lot of this is actually common sense, okay? And we'll talk about these in each of these components here. But anyway, so this is basically the law that's going to be governing how much or how quickly drug is going to be getting through these membranes here, okay? So the first component we're going to look at is going to be the concentration gradient, right? C1 is going to be the amount of drug at the higher concentration. C2 is going to be the drug at the lower concentration. So if I have less drug on C2 and more drug on C1, what is that going to do to my ultimate flux through that membrane? It'll be greater because the concentration gradient is greater. That makes sense, right? So again, it's like putting a ton of, so I just saw an example of passive diffusion right as we finished the test, and I saw all of you who had a very high concentration gradient, about 29 of you on the outside of the room, all flooded in here because there's only one student on this side, right? Makes sense? So again, the more of a difference that is, the more flux you're going to have going through there. That's why when you look at like transdermal products, like so those patches, they have a ton of drug in there because the more drug they have on the outside, the more it's going to force it through to have that flux there. So the concentration gradient is the first thing that's going to be important here. The more drug I put on one side, the more it's going to be able to get through, okay? And again, similarly, you'll get to a point where there's an equilibrium where the concentration gradient will be 0 and you won't really have much flux there, right? That's a kind of homeostasis point that you'll see there. The next step is going to be the area that we're going to be able to get through. So the larger the area that the drug has to get through, what does that do to flux, you think? So a larger area for a drug to contact. Actually will increase it, right? So again, imagine your GI tract, right? So is your GI tract just one long smooth tube? No, it's got all these villi and it has all these different, this brush border that increases the surface area by an extraordinary amount. That is important because the more surface area you have, the more contact the drug can have with that, the easier it's going to be to get through, okay? So and I'll show you some pictures of this in just a second. But just imagine if I were to say place a drug just on 1 square inch of skin versus if I were to slather your entire body in the drug, which one do you think would have more absorption? The whole body being covered. So the more area you're covering, the more likely you are to have absorption. That's important. Actually, in some cases, we can see this where patients have like inflammatory bowel disease, like Crohn's and things like that. They can actually really kind of wipe out a lot of that brush border, and that can make it hard to absorb a lot of things from the GI tract because they have less area to do so. Okay. Anyway, the next thing is going to be the permeability coefficient. This has to do with how lipophilic the drug is and how easy it's going to be able to cross over. So again, the higher the coefficient, the more likely it's to cross over. This is probably the thing you're going to least think about clinically, but every drug has sort of an inherent sort of cofactor there, or coefficient to think about. And then finally, you're going to see thickness is going to be here. This is thickness of the membrane in the denominator. So the thicker the membrane, what do you think that's going to do to flux? It's going to lower it, right? So again, the thicker the membrane. So imagine if I were to apply a drug, say, to the soles of your feet versus if I were to, say, apply it to your armpits. Which one do you think would have better flux? The armpits, right? And actually, that's one thing you have to be really concerned about is when you're applying, say, topical products to different areas of the body. So, for instance, we can give you, say, you have eczema, right? You have an inflammatory condition, and we were to give you steroids. Certain steroids you cannot use on really thin areas of skin because so much of it gets absorbed, you can see side effects, right? Versus thicker areas of skin, you can use higher concentrations of the drug because you know it's going to have a harder time getting over there. So thickness of the membrane is going to be really important. And again, most of this is common sense, right? So the bigger the concentration gradient, the larger the area, and the thinner the skin or the thinner the membrane, the easier time you're going to have to cross over, okay? That's basically what you need to know about that. Again, the more we can modify this to our purposes in terms of either applying to a larger area or by changing the concentration gradient, the more likely we are to have more flux going through those membranes, whether it be the skin, whether it be through the GI tract, whatever happens to be there, okay? And again, this is just kind of a pictorial example kind of showing you what is going to be governing this. So the larger the area, the thinner the thickness of that membrane, and the larger the concentration gradient are the most important things there. Now again, some drugs are going to be so, say, hydrophilic, they have a almost impossible time crossing over, and we have to know about that. We have to know that maybe there's carriers that can help it out. Maybe we have to give it via a different route. Remember, not every drug can be given orally. Not every drug can be given topically because they just have too hard a time crossing over, okay? So again, this same thing applies to lipid diffusion here. It's just that the lipid barriers are going to be the main thing that's going to be stopping medications from crossing over, right? So the drugs have to have a certain degree of lipophilicity to undergo this passive diffusion through these membranes here. Now, this gets a little bit more complicated when you start to think about pH of the fluids that you're going to be dealing with here, right? So does anyone remember the Henderson-Hasselbalch equation, perhaps from chemistry? It's going to rear its ugly head again. So I apologize ahead of time, but this is an important concept to consider, and I'll give you some clinical examples of where this matters. But basically, pH of the solution that the drug is in will dictate its ionization state. What does that mean? That means that if I have a drug that has a positive charge on it, do you think that makes it more lipophilic or hydrophilic? Hydrophilic, right? Because again, just like you think about salt, like sodium and chloride, it's a positive and a negative, it's very water soluble. So if it has a positive charge on it, it's more water soluble, okay? It's more polar. If it is uncharged, that means it's more lipophilic. And what do you think it does to flux? It's going to be better because it has an easier time crossing that membrane, okay? This is important when you consider things like, what's the pH of, say, the stomach normally? Very acidic, it's like 2, right? Versus when you get into the small intestine, what do you think it gets around to? It's much more neutral, like 7 to 8, right? Because you have a lot of bicarb being secreted by the pancreas, right? It tends to increase the pH quite readily because you don't want all that stomach acid melting away your small intestine, essentially, right? It doesn't have the same kind of protection like your stomach does. So based on that, you can see that the ionization state of the drug will change pretty significantly, which may make certain things absorb more easily, certain things absorb more difficult, have a harder time doing so based on that. And also, I'll show you some examples here and how we sort of figure this thing out. But we'll mainly talk about this in terms of weak acids. There are also weak bases that are out there, and I'll show you how that plays a role additionally. But just know in general that a charged drug is going to be more lipid insoluble, more water soluble, and a uncharged drug is more lipid soluble but water insoluble. Okay, there's always going to be a balance here, right? There's always going to be a kind of a homeostasis that develops here.
What about the molecules with negative charge?
So in those cases there, that we can still consider that to be pretty hydrophilic. Yeah, so it's just, and when I say positive charge, I'm just saying if it's charged at all, that makes it hard, right? So anyway, so a couple of things you want to look at here. So one is the pKa of the drug itself. Every drug will have a pKa. It also has a pKb, but most often we talk about it in terms of the pKa. Sorry, so the pK of the acid itself. This is what's going to tell us. Basically, it's 50-50 ionization point. So essentially what this means is, say, for instance, I have a pH with a solution of 7, and I put a drug in that has a pKa of 7. That means 50% of it is going to be ionized, have a hard time crossing. 50% of it's going to be unionized, have an easy time crossing. Okay? If I have a drug with a pKa of 3 and I put it into a pH solution of 3, that means it's going to have that 50-50 point there, right? Again, I will show you why this is important in just a minute, but I want you to at least keep this in mind right now, okay? Some of the nomenclature I'm going to be using here. So again, if you're thinking about a weak acid, you're going to find that when it is protonated, meaning it has an extra hydrogen ion put in there, because again, what makes a solution acidic? Oh, the hydrogen ions, right? So again, when I put a weak acid into a acidic solution, you're going to see it's going to pick up one of these hydrogens. It becomes protonated, and thus it is uncharged, which means it's going to be more lipo or hydrophilic? Lipophilic, right? There's no charge on this thing right here, right? Versus if I were to say take away the hydrogen ion, it becomes unprotonated. Now it has a negative minus on it, right? So that means it's going to be more hydrophilic at this point, okay? That means it's charged. The opposite is true for bases. So if I were to have, say, a base that were to pick up a proton or a hydrogen ion, you're going to see it becomes charged at that point, okay? And so this means it's protonated, it's charged, means it's a harder time crossing over because it is more hydrophilic. And the flip side is true as well. When it loses that, you're going to find that it's going to be just in the normal base form. It is unprotonated, but it is uncharged. So kind of the opposite is true here. When acids pick up a proton, they become uncharged. When bases lose a proton, they become uncharged. Okay? Just take some time to kind of wrap your mind around that a little bit. But one of the big takeaways I want you to think about is that like dissolves like. Okay? If I put a weak acid into an acidic solution, it's going to pick up all those protons, and it's going to be much more in this state here. If I put a weak base into a basic solution, it's going to lose all those protons, and it's going to be in this uncharged state, and it's going to get absorbed very well. Okay? So like dissolves like. Always kind of go back to that focal point, and it should make some of this a little bit easier to digest a little bit. So to give you an example of what this looks like, so imagine if I had a weak acid here, and you're going to see, again, it's a constant, right? You're going to find that the drug will be in this equilibrium between picking up and dropping off protons, but again, by changing the pH of the solution, you can kind of force the equation either way into favoring one versus the other. So as in this case here, you're going to see when I have a weak acid, when it drops that proton, which you can see right here, it's going to just bounce off that lipid membrane. It's going to have a hard time getting absorbed there, right? Versus if I were to say put it into a more acidic solution by driving more protons in here, it's going to drive it over to this side of the equation, right? And now it's in that protonated but uncharged state. It's a very easy time crossing over. And then you have to think about also there's even times where the pH of the different solutions on either side of that membrane can actually change. And you have what we call ion trapping. So a good example of this is one of the things we are concerned with giving drugs to women who have just had a baby is what? They're breastfeeding, right? So the pH of the breast milk is actually a little different than the pH of the blood that's where it's coming from. So that actually means some drugs, they will be able to get absorbed into the breast milk, but then they get stuck there because the pH has changed such that they're in a more charged state and they can't cross back over. So what does that do? Well, that means you have all that drug concentrating in the breast milk, and then who gets it after that? The baby gets it, right? So then that's a concern. So again, this shows you how this can actually clinically make a difference. Now, as a clinician, are you really going to be thinking about this all that too strongly? No, but I want you to think about the concepts that go into it. So when you read about a drug and its effects on breastfeeding, you can think about that. When you hear things like proton trapping or ion trapping, when you think about things that it concentrates in the breast milk, that's what we're talking about. This is the kind of the underlying concept there. This also means that by changing the solution, the pH of the solution, that can affect how well drugs get absorbed, right? So for instance, aspirin, anyone know the abbreviation for aspirin? ASA. ASA, anyone know what that stands for? Acetylsalicylic acid. So stands to reason that aspirin is probably 8-week acid, right? So for instance, if I put aspirin into a basic solution, do you think it's going to have an easy time getting absorbed? No. But if I put it into an acidic solution like the stomach, it's a very easy time getting absorbed, right? So aspirin, in a lot of cases, actually gets absorbed very easily from the stomach.
Why do we give baby aspirin? Is it aspirin sublingual? No.
Not typically, no, yeah. Yeah, so the nitroglycerin you give sublingually just because it has no bioavailability otherwise. But anyway, so again, the flip side is going to be true here for weak bases as well. If I put a weak base into a solution that has more protons in it, a more acidic solution, you're going to find that it is going to be in this charged state, it's going to bounce right off. Versus if I put it into a more basic solution, like dissolves like, a weak base in a basic solution will allow it to easily cross over, and the same trapping can actually happen there. Okay? Everyone with me so far? Hope so. Getting a lot of blank stares. I'm going to assume you're with me, right? I'm just being very stoic right now. But when you actually get down to it, and again, I'm not going to have you calculate this on an exam by any means, but again, the concept is what I want you to drive home here. So looking at the pH of the solution is going to be equal to the pKa of the drug itself, and it's going to be based on this ratio between the non-protonated versus the protonated species here. So this just goes to show you by modifying the pH of the solution, I can modify how well or how much I'm going to be favoring one form of the drug versus another. Okay, so I'll give you a good example of this that I use clinically quite frequently, right? So I take call for the poison center, and say I have someone who overdoses on aspirin. Okay, take a whole bunch of aspirin. Is aspirin dangerous in overdose? Anyone know? Yeah, it's really bad, right? It can actually be very, very severe. It can be very deadly potentially, right? So if I have someone who's overdosed on aspirin, I can use my knowledge of this concept to say, okay, well, how can I get rid of aspirin more quickly? Okay, well, I know aspirin gets eliminated through the kidneys. It's going to go out through the urine, but how can I affect that? Well, if aspirin is in a more acidic solution, I know it's going to be more in the uncharged state. I know it's going to be absorbed from the renal tubules pretty easily. That's no good because I want to get rid of this stuff, right? So how can I prevent that from occurring? Well, what I can do, anyone know what I can give to basically alkalize the body to make it pH higher? Sodium bicarb, right? So I can give the patient sodium bicarbonate to raise the pH of the urine to put aspirin in that charged state. So that way it just bounces off those renal tubules. It can't be reabsorbed, and they pee it out that much faster. So I can enhance the elimination of aspirin by giving sodium bicarb. Okay? So again, it's a real-world application of this principle here. By changing the pH of the blood and the urine, I can actually affect how well drugs either get reabsorbed or I can get rid of them more quickly. Okay? So you can go back and review this if you need to. So I post these videos up so that way you can listen to it again and make sure it really sinks in here. Because I want you to understand this. Because again, I'm not going to ask you to calculate the ratio between the unprotonated to the protonated species, but I want you to understand is that, hey, if I have a drug that I'm giving and I change the pH in one direction or another, how's that going to affect the absorption of this drug that's a weak base or a weak acid? I want you to be able to apply that concept. Okay? Something I want you to know.
Question?
Yes?
So if you have a low pH and a higher pKa, that would mean that more is unprotonated?
More of it is going to be, so usually the higher the pKa is, you're going to find there's going to be more. Again, if you go back to the last slide here, by lowering the pH here, and say I have a relatively high pKa, you're going to be finding that you're actually going to be sending it more to the non-protonated species there, right? So again, there's going to be more charge in that case, right? But if I were to drive it even further, I would say lower that pH, you're going to find you have more of that protonated species there for a weak acid, okay? Again, just remember that like dissolves like. If I put a weak acid into a basic solution, is it going to get absorbed or go through a membrane? No, it's going to have a hard time, right? That's kind of the baseline of what I want you to get out of this conversation here. But I want you to understand the background of it so that way you can apply it clinically when it comes up. Or on a test question, which is more likely, right? Anyway, so this gives you a good example here looking at, say I have a drug that has a pKa of 7, and now we're going to put it into a neutral solution at 7, you're going to find this is a 50-50 split between the protonated versus the unprotonated species here, right? And again, by modifying the pH of the solution, then you can change that pretty greatly, right? Another good example of this is calcium absorption, right? What kind of patients require usually a lot of calcium supplementation? Older patients, right? Because you're worried about what? Osteoporosis, which leads to what? Fractures, disability, morbidity, mortality, right? So again, this is a big concern. So we think about, okay, well, let's give them some calcium, right? Well, calcium prefers to get absorbed in more acidic solutions. Well, oftentimes older people also have a lot of stomach issues as well. So what if I give them a drug that modifies the pH, say, of the stomach by inhibiting stomach acid production, right? Ever heard of a PPI before? Or like Zantac or something like that? It's a histamine blocker, right? All those raise the pH of the stomach. That can actually decrease the absorption of calcium for those patients. So you may have a patient who say, hey, I'm taking calcium every single day, but you still find that the DEXA scans are going the wrong direction, their osteoporosis is not getting any better. We'll look at what kind of drug interactions do you have there. Is something affecting their ability to absorb calcium by changing the pH, right? So clinically this comes up all the time, whether you really think about it or not, right? Anyway, so as I mentioned, an acidic solution, weak acids tend to be more protonated, they're uncharged or more lipid soluble. Weak bases tend to be more protonated, they're going to be charged, but they're lipid insoluble, okay? So anything you put into an acidic solution is going to get protonated. It's just a matter of whether or not it's going to become charged at that state, right? Whether it becomes ionized. And again, just to give you some examples here of different products here, weak acids, weak bases. Don't memorize this by any means, but just know that every drug is going to have one of these points. Clinically, you may not really think about it too much, but it does come up, right, in terms of like how I'm going to be formulating things, if I'm going to be putting it into a certain type of solution. So IV solutions have a pH to them. That can all make a big difference there, right? If you notice here, aspirin has that pKa of 3.5. So again, when it's in that pH of 3.5, say in the stomach, you're going to find that 50-50 split between protonated versus unprotonated, right? So that's why it's going to get absorbed a little better in the stomach than it would, say, in the small intestine, where the pH is much higher. Okay, so looking at special carriers, again, this is going to be good for substances that are either too large to get through a membrane, or they maybe are too hydrophilic to get through that membrane, whatever the case may be there. But we have special transporters that either help to push things out to get rid of them, or to try to absorb them and get them into the system there, right? So if you think about it, your brain is a pretty protected sort of area there. Have you heard of the blood-brain barrier? What is it? What's its main function? Keep stuff out, right? You want to keep the CNS as free of junk as possible, toxins, bacteria, anything. So we have special transporters that try to force things out of there. That's why some drugs are not able to cross over into the blood-brain barrier to have their mechanism of action, right? So if you think, anyone ever heard of the drug Imodium? It's used for diarrhea. It's actually an opioid, right? But it doesn't cross into the blood-brain barrier to actually give you that euphoria you're looking for, because it is not able to cross over, right? So again, think about things like these transporters that help to push drugs out of the system in order to protect certain areas. The GI tract does the same thing. Sometimes we have carriers to try to draw things into it, right, that can't otherwise be absorbed there. A good example of this would be something like iron has a hard time going through passive diffusion, so it has special carriers that will allow for things like endocytosis to occur there. But just know that these cases here, they're not governed by Fick's law. So what you find with Fick's law is that as long as I keep driving up that concentration gradient, I can keep increasing flux, right? There's really no limit to it for practical purposes. With carriers here, you're going to find that there's only so many carriers, so once they're all bound up with drug, they can't really do much else. So this means there is a limit to how fast they work. It also means that it is energy dependent in a lot of cases there, so if there's no energy, guess what? They don't work, right? So you have to consider that as well. And again, they can go against the concentration gradient. So that's why the brain can force things out of it, even though the concentrations may be almost zero in the brain, but force it out against the concentration gradient, but it requires energy, okay? So here's an example of this. This is called an MDR1 transporter. It's a multi-drug resistant transporter, and it's actually also known as P-glycoprotein. It's an important transporter. This is actually something that kind of lines the GI tract and will shuttle drugs out of the body into the GI tract for elimination, right? It also is found on the brain as well to keep things out. This is actually really important. So did I mention the grapefruit juice interacting with drugs previously? This is another example of that. Not only does grapefruit juice inhibit certain enzymatic or certain enzymes in the liver, but it also inhibits this protein here. So that means that patients will absorb the drug, but they're not really eliminating it out through these transporters as much anymore. So that means, what does that do to the levels of the drug? It's going to increase it, which can lead to things like toxicity, right? So that's a big concern. That's why we talk about not having grapefruit juice and mixing it with certain drugs, is because of the effects on this transporter and certain hepatic enzymes you're going to see there, okay? Again, it's not important to remember necessarily, the names of all these different proteins here, but just know the concepts behind them. Yes, we have carrier-mediated diffusion. Know that it requires energy in a lot of cases, can go against the concentration gradient, and once they're saturated, they can't work any faster, right? They have a certain speed associated with them, and once they're saturated, you can't really do much else with it. Okay. Here's some examples of how these work as well. So again, here is some hepatocytes. And here's how drugs actually get eliminated into the bile, right? We mentioned that's one form of elimination we can have there. Here's using these proteins to actually shuttle drugs into the bile, and then it can be eliminated through the feces, right? Here's some enterocytes, and they can use PGP as well to force things against the concentration gradient back out into the GI tract to be eliminated, right? Different ways to do this, kind of the same thing, is to rid the body of those medications there. The opposite can occur, though, as well, right? You can have transporters actually get stuff into the body additionally, okay? Okay. Other things, endocytosis is a process. Anyone remember endocytosis from like basic biology? What is that? It's like, yeah, basically kind of engulfing something to absorb it, right? So again, if anything is not able to get through passive diffusion to the membrane, if it's not able to go through carrier-mediated transport, usually this is for really large molecules, things that are lipid insoluble or otherwise impermeable to that cell there. And again, they basically get engulfed by part of the cell membrane. It'll pinch off essentially, and then it can go off and do something else. You think about things like, what's the opposite of endocytosis? Exocytosis, right? Then the same process is happening there, where basically it's just going to be that vesicle is just going to emerge with the cell membrane and then release the substance. A lot of the times this happens with things like neurotransmitters quite frequently, right? So think about the nerve terminal releasing things like norepinephrine or acetylcholine. That's that exocytosis process. Endocytosis is just going to be the opposite there. And just some examples of where this occurs is things like B12 absorption, iron absorption, all requires endocytosis to occur for that absorption to happen. So why is iron so important? Why do we care about that? Right, because we need it for our hemoglobin, so if we don't have iron, then we get anemia, right? So that's an important concept there as well. Like, do they even have the ability to absorb that stuff? And a lot of people with GI issues may have a hard time absorbing that iron, right? So things to consider. Exocytosis, as I mentioned, just the opposite process there. Things like calcium into the bloodstream or pancreatic enzymes, hormones, all those are going to undergo exocytosis. Again, just kind of releasing that back into the bloodstream. Again, just an example of what this looks like. Again, exocytosis where you're going to be expelling products, endocytosis where you're going to bring it in. It just pinches off that membrane to form that vesicle there, right? Okay, so that's how absorption is mainly going to occur, right? And so again, I can ask you on a test question, I say like, okay, well, I have a drug that I'm applying on, say, a 1 by 1 inch patch to the body, and then I can say, well, let's upsize it to, say, a 2 by 2 patch. What does that do to the amount of drug that person is absorbing? It's going to increase it, right? So again, know how those different factors are going to be affecting permeability, right? If I say I have a weak acid and I increase the pH of the solution that the drug is in, what does that do to absorption? It's going to, yes, I increase the pH, but it's a weak acid. It's going to decrease the absorption, right? Because again, like dissolves like, and the opposite is also true. Like does not dissolve in unlike things, right? So that's absorption. Next up, we have distribution. You're going to find that a lot of the same principles are going to be applying here as well. And so the big concept to consider here is called volume of distribution. This is kind of a tough one for a lot of students to get just because it's a little bit more of a theoretical sort of number here. But essentially what this means is how far out into the tissues does a drug like to travel, right? So I talked about marijuana and THC last week or maybe the week before. Okay. Again, I always like to go back to illicit substances, not for personal reasons, but just because that's my job in a lot of cases. And so I see a lot of this stuff, and it becomes clinically really important. So imagine, a drug like THC. Like, what do you think about THC in terms of like, what have you heard about like drug screens been passing? How long does it last in the urine? Short period of time, long period of time? Weeks sometimes, months sometimes. How do people consume marijuana? Smoking usually, but what else can they do? Ingest it, right? They can cook with it, right? You can get your pot brownies, you can make some pizza. In fact, if you look at a lot of marijuana products, they usually incorporate it into butter first. So what does that tell you about the physiochemical properties of THC? It's fat soluble. It's very lipid soluble, right? That's a very important concept to understand with that. That's why you find it in cooking oils and butters, and that's why it's included in a lot of the edibles, okay? So THC, which is the active component, this is the main psychoactive component. Anyone know what the other big component of marijuana is? CBD, right? Cannabidiol. But we're going to focus on THC right now. That's the main thing that kind of gives you that high, that euphoria. And so THC is very lipophilic, right? So we kind of discussed that already based on the edibles and things like that. So when it gets into the tissue, do you think it likes to stay within the blood, which is mainly a sort of a water-based compartment, or do you think it likes to go into, say, the adipose tissue? Let's go into the adipose tissue, right? So it distributes very far out. So that has a very large volume of distribution. It doesn't like to stay in the blood. It likes to go out into the tissues there, which means that when you have someone who's using marijuana pretty chronically, right? They're using it sort of, say, day in and day out. They're using pretty high dose. Their tissue, their adipose tissue builds up and builds up and builds up stores of the stuff, which is why they can stay positive on a urine drug screen for sometimes weeks to months after their last use. Because they just have this stuff just leaching out into the bloodstream, right? There's going to be that equilibration that occurs there. So as they eliminate it from the urine, more of it's going to come from the fat tissue, but it has so much built up, they stay positive for a long period of time, right? One time I had a friend who said, oh my gosh, I went out to Colorado, it was a couple years ago, and they said, I went to Colorado and I smoked pot once. I got a drug screen coming up, am I going to be positive? And I said, well, and the person's like skinny as a rail, no fat tissue on them whatsoever. One time, and I said, nah, you're probably going to be fine, right? But if it had been someone who says, like, yeah, I smoke like 3 times a day, and I've been doing it for 6 months, and they weigh 300 pounds, they're probably going to be positive for a lot longer, right? So again, we think about these things in terms of their distribution and how much of a tissue store they've actually built up there. Yes, I don't know, whichever one you use first. I don't know.
I
Hey, your neighbor, yeah.
Oh, sorry. Do those tests have like levels, like number levels, or is it just positive and negative?
Yeah, so you're talking about either qualitative or quantitative, right? So sometimes usually when you get the result back, it'll be a qualitative, meaning yes, no. But certainly when they're running the assays, they will get a level, and depending on the threshold of that level, it'll say positive or negative, right? But certainly you may not see that when you actually get the results back. Usually you as a clinician will just see yes, they were detected or no, they weren't detected, right? Doesn't mean it's not there, it just may have been under that level of a threshold. I remember I went to UF for pharmacy school, and I remember one of our professors being like, yeah, if you set the threshold different places, you're going to find people maybe positive or negative, And it's interesting that FSU never had a positive test on all their urine drug screens because they maybe set the threshold a little too high. I was like, wow, that's some pretty strong words there, but anyway, it's what it is, right? So, yes, ma'am.
Okay, so is it safe to say that the more lipid soluble something is, the greater volume distribution it will have?
That is the key point I want you to take away from that. The more lipophilic the substance is, the bigger the volume of distribution is going to be, okay? That's a key takeaway from this. I want you to think about that as we get into the specifics of it. Basically, it just means that what kind of volume of water would I have to put an amount of drug into in order to get the concentration that I'm drawing off of your blood, right? So say, normally we check drug levels for a patient. Normally it's going to be taking a venous sample. You measure that and you see how much drug is there, right? So if something has a large volume distribution and I measure it from the blood, do you think a lot of it's going to be there in the blood, or is a lot of it going to be in the tissue where I can't measure it? It's going to be out in the tissue, right? So it'll have a relatively low level. Something that has a low volume distribution is much more hydrophilic, likes to stay in the blood. If I were to measure that blood sample, what do you think that level would be? Higher or lower? It'd be higher because it's sitting right there in the bloodstream, right? So I'm measuring it all, okay? So again, this is a theoretical number, but it's good because, one, it can help us to compare and contrast drugs to one another. Patients, based on their clinical condition, may change their volume of distribution, right? So imagine I have someone who has CHF, heart failure, and they're very edematous. They have a ton of extra water. That can affect the volume of distribution of drugs. Imagine I have someone who has a ton of adipose tissue versus someone who has no adipose tissue practically. That can affect the volume of distribution pretty greatly, right? So again, a lot of it is going to be dependent on patient factors, and it's very drug specific as well, as I give you some examples here. So again, how do we actually calculate this? And I'm probably not going to actually put a question on there saying, hey, calculate the volume of distribution of this. But I want you to know what the different factors are going to be when you're calculating this to determine, okay, well, how is this going to change my levels, right? How is this going to change the effect of the drug depending on the situation? So basically what you're running into is that the volume of distribution, this is usually measured in liters. So again, it's important to keep your units straight. Is going to be equal to the amount of drug in the body. So again, if I give you, say, 500 milligrams of something IV, again, what's the bioavailability of the IV route? 100%, right? So again, let's assume we're going IV until proven otherwise, that we're using, say, 100% bioavailability, right? So whatever I put into the bloodstream, that's the dose we're giving there. Is the amount of drug in the body. It gets divided by the concentration in the plasma. And that's usually going to be in milligrams per liter, okay? Or sometimes you'll see micrograms per ml, but it's the same thing essentially, just by a factor of 1,000. So looking at this, if I were to say have a drug that had very high volume of distribution, keeping the dose of the drug the same, but the plasma concentration was very low, that would tell you that the drug is out there in the tissue, right? That means that it does have the high volume distribution versus as a low volume distribution, this would make my concentration in the plasma likely higher, okay? Because again, it likes to stay in that central circulation. So just to give you an example of this, imagine I were to give 25 milligrams of a drug, and again, administering IV. The plasma concentration is then 5 milligrams per liter. By plugging that in, let's just say 25 divided by 5, I would then say that my volume of distribution is 5 liters, okay? So typically, as I mentioned, that high volume of distribution drugs are going to be more lipophilic, and they're distributed very extensively. Things with low volume distribution tend to be, is it Miller time? Sorry, just checking. It's not Friday, man. Come on. I don't know. I'm totally thrown off. No, just kidding. It is your Friday. There you go, right? Ever enjoy a nice American brew for... No, I'm just kidding. Don't do that. No. Always 4th of July responsibly, okay? I don't want to see any hands lost from a fireworks accident or something after this week. Anywho, so again, as I mentioned there, if the thing has a low volume distribution, you're going to find more of it in the bloodstream because, again, it's not distributing out to that adipose tissue. Okay, so just to give you an example here, and I kind of think about volume distribution, how big of a tank am I filling, essentially, with this drug here? And so let's say I have 2 drugs. One is going to be hydrophilic, which means it likes to stay in that central circulation, likes to stay in those water compartments, water-based compartments. And then drug B is lipophilic. It likes to be out there in the tissue, likes to partition into that adipose tissue, among other things. So I'm going to give 50 milligrams to 2 individuals, and they're identical twins. So you assume everything is the same between them. And so then I draw blood levels, and I'm going to say, okay, well, what's the actual concentration of the drug in that person's blood? For the person that got drug A, it was 10 milligrams per liter. For the concentration for the person who got drug B, it was 0.5 milligrams per liter. So the person who had the lipophilic drug, you notice that less of the drug is there in the blood to measure, more of it's out in the tissue, right? So it's a much larger volume of distribution. If you calculate it out, it'd be 100 liters, versus the person who got the hydrophilic drug, much more of it is going to be there in the central circulation, right? 10 versus 0.5, right? And you're going to find that it has a much lower volume of distribution, only about 5 liters.
So volume distribution and concentration in plasma are inversely related?
Mm-hmm.
Okay.
So a person with really low body fat, 4 or 5%,
Mm-hmm.
if you want a drug to go into the tissue, what, would you just give more?
Yeah, so sometimes if you're not getting enough to the site of action, sometimes you have to give more potentially. A lot of times you're going to find that adipose tissue isn't necessarily the site of action, right? So sometimes it's not where you necessarily want the drug to be. So for instance, if you have, say for instance, a bloodstream infection, I don't really care what your adipose tissue levels are because the infection is in the blood, right? So sometimes it's clinically not really relevant. However, I will tell you that sometimes when we're dosing drugs, patients who have an excessive amount of adipose tissue, we want to make sure we're not giving them way too much drug just based off of their weight. So sometimes we have to adjust that sort of thing if we have really obese patients. But yeah, clinically it depends on the situation for sure. Okay. Okay.
Question.
Yes.
So volume distribution is not really like dictating the efficacy of a drug?
True, but if you're not getting enough drug to the site of action, then it may decrease efficacy, right? Exactly. So where do you want that drug at? Where do you want it to work, right? Exactly.
So in that last example you gave, you could say that the person that received the drug B was probably had more adipose tissue?
No, because again, we said they're identical twins, so they're identical in all factors. So say they're the same exact weight, same body fat percentage. It's just what changed though, the drug, right? The drug was more lipophilic, so it partitioned to whatever tissue they had, versus the other drug was more hydrophilic. Okay. So again, the point of that was to keep everything the same, the dose, keep the patient the same, but we're just giving a different drug that had different properties to it, right? So that leads into this example here when you're looking at this, and that typically what we do in order to compare drugs to one another is that we'll convert the volume of distribution to liters per kilogram, and then I can actually apply that to a patient. So if I have a patient who weighs 100 kilograms, I can apply that to get what their volume of distribution is, versus if they weigh 20 kilograms, I can apply that there, right? If I had a pediatric patient, for instance. So most of the time when you're looking up the kinetics of a drug, which you might have to do for a homework assignment potentially, is you can look here to see, like, okay, what's their liters per kilogram, what's their volume of distribution. I will tell you a good handy number to remember is if it's less than 1 liter per kilogram, that's considered to be low volume of distribution. If it's greater than 1 liter per kilogram, it's considered to be high volume of distribution. Let me give you an example why this matters. So for instance, say for instance I'm taking care of a patient who has overdosed on, say, aspirin. Let's go back to the aspirin instance again. Aspirin tends to have a relatively low volume of distribution, likes to be there in the bloodstream, right? Well, that makes a difference when I'm looking at ways to get rid of the drug. One of the ways I can do that, say if the kidneys are not working well enough on their own, I can use an artificial kidney. Right? What is that called? Dialysis, right? I can do hemodialysis to try to pull a drug off. Well, would I be able to do that very well if the drug was so lipophilic that it's all out into the tissue? Well, no, because I'm filtering the blood. I'm not filtering the adipose tissue. So I can't really get rid of the drug that well. But aspirin being something that has a low volume of distribution, more of it's in the bloodstream, I can pull that off much more easily with the hemodialysis, right? And so sometimes whether I can use dialysis or not to get rid of a drug can be very dependent on the physiochemical properties, including its volume of distribution, right? Some other factors as well, but this is one of the big components of it, okay? So just to give you some examples here, and you don't have to know all of these drugs yet. We'll get into all of these in the subsequent classes, but just to show you that it can change greatly depending on the type of drug you're dealing with, whether it's something like heparin. Anyone know what heparin's used for? It's an anticoagulant, right? We use it to prevent clots or to treat clots, all the way through something like propranolol, which is a beta blocker people might have heard of. Digoxin, I mentioned as an example in one of the previous classes. That's something that's used for arrhythmias or CHF. So again, the doses can range. The nice thing for you, though, is that clinically you won't need to think about this a lot of times because most of the time the drug dosing has already been figured out to where it won't matter to you. but clinically it can come up, right? So if I have a patient who has a drastically modified volume distribution, as I mentioned, due to volume status, so they have too much water or too little water, they have burns, they're particularly obese, things like that, this can really monkey with these and make you change your dose based on that specific patient there. Okay, so sometimes these things do come up. I'll give you some more examples later on. So let's imagine we have a patient and we're trying to estimate the plasma concentration. So I want to give a patient kind of a standardized dose, but I want to kind of estimate what his plasma concentration is going to be. We have a whole section later on called therapeutic drug monitoring, and the whole point of using blood levels of drugs is to do what, do you think? Make sure they don't get too much and make sure they don't have too little, right? You want to keep them in that nice Goldilocks zone where they're going to get efficacy, but hopefully limit toxicity, right? So this is why we measure plasma concentrations. But let's say, for instance, I'm going to give this 70 kilogram man, I'm going to give him 100 milligrams of this drug C that has a volume distribution of 0.6 liters per kilogram. Okay, I'm giving it to him IV. So what's my bioavailability? 100%, right? So I don't have to worry about the dose getting, going to first pass effect or something like that. So what is his estimated plasma concentration? Well, we can figure that out, right? We can estimate what it's going to be based off of the factors that we know. We know the dose, we know the volume distribution, and we know the weight of the patient. Using those three things, we can come up with an estimated plasma concentration for that guy. So let's say, go back to our equation here, basically volume distribution equals dose over C0. C0 means that initial concentration, okay? D stands for dose, VD for volume distribution, okay? Now, how do I get my volume distribution for this patient? Well, I got my VD in 0.6 liters per kilogram, so I multiply that by what? What other kilograms have we seen? His weight, yeah, exactly. So you multiply that by his weight in order to get what the specific volume distribution is for that particular patient. So I take 70 times 0.6, and that will give me this 42 liters here, okay? So that's that patient's volume distribution for that particular drug, okay? So again, that's why you can take that liters per kilogram and apply it to any patient you want based on their own specific weight, okay? Then that's going to equal the dose I'm administering, which is 100 milligrams, and then it's going to be divided by that C0. Well, this is what I want to solve for. This is the one unknown I have in this instance here. So I can rearrange the equation, right? Everyone remember their basic algebra, right? Again, I had to take like calculus in order to get into pharmacy school. By the time, how often I use calculus? Never. You know how often I use algebra? All the time, right? We're always solving for unknowns, right? So this is a very important thing to consider, especially when you're doing like pediatric drug dosing, when you're trying to figure out how much volume, how many mLs of a drug to give to a patient. All of that is based off simple algebra, right? So you got to be able to rearrange these equations here. Anywho, so let's solve for C0, right? So I can basically kind of switch this around. So C0 equals 100 milligrams, which is my dose, divided by the volume of distribution for that patient, which is 42 liters here. So I would estimate, based off of this, and again, here you're going to find that you don't have to cancel out in units here, but it's going to equal 2.38 milligrams per liter. So now I can compare that and say, well, what's the therapeutic dose? What's the therapeutic level I'd be looking for? If my therapeutic level is, say, a range of 5 to 10 milligrams per liter, what would I need to do that patient's dose? I have to give more, right? Because again, I can't change the patient's volume distribution on my own, right? I can't just change that. It's something the patient is sort of responsible for, so to speak. But I can definitely change the dose as a clinician, right? So again, if it was, say, the level I was shooting for, say, 0.6 to 1, what do I need to do for that patient? Give a lower dose, right? So I can show you how clinically this becomes really relevant. Certain antibiotics we have to do this with pretty frequently. If you're lucky and you work in a hospital and you have to dose something like vancomycin or an aminoglycoside, hopefully you have pharmacists there. You can just say pharmacy to dose, and you don't think about it. But you might be working in places where you don't have that available, and you have to do it yourself. And so this is the kind of stuff you're going to be doing to figure out, okay, well, what's the kind of estimated dose I need to be giving this patient to get that right concentration? Okay.
Question.
Yes.
Like when it comes to weight for the volume distribution, would you consider maybe like one person maybe heavy because of fat versus one who's just muscular?
Yeah, absolutely. So those are things you have to consider there. So for instance, you have a patient who weighs, let's say 250 pounds, right? One could be a bodybuilder. The other one's going to be someone who's a couch potato, right? And so certainly that will affect the volume of distribution because the adipose tissue is going to be a better reservoir for that drug than muscle will, right? So in some cases, we have to draw that distinction there. So again, when you're just looking at a chart, sometimes you may not be able to tell that. But when you go and lay eyes on the patient, you can say, oh, wow, this patient is, has a lot of adipose tissue. Perhaps I need to adjust the weight. And again, this kind of goes beyond our scope here, but yes, you will consider that. You will consider, okay, well, maybe I need to adjust some things to make sure I'm not overdosing this patient. I give them too much based on the amount of adipose tissue they have, right? or too little potentially, as the case may be there. Yeah, that is definitely something you have to consider there. But a lot of times these patients, I mean, if you think about like, you know, guy's 250 pounds, bodybuilder, do you think he's going to end up in the medical ICU very frequently? Less likely than someone who's, you know, pretty heavy set, has other cardiovascular problems and things like that. But certainly if you're working in the surgical ICU, those guys get into traumas all the time. We had one coworker a couple of years ago, and the guy was like just massive bodybuilder guy and got into a massive car wreck, but he was in the hospital for 3 months or so. And so they had to consider things like, okay, well, what kind of muscle breakdowns is he having? How does that affect things like his creatinine, you know, volume distribution? All those things make a big difference based off the habitus of the patient. Yeah, so that's a good question. Yeah. Anyway, so some things that can modify the volume of distribution, things that can decrease that. Okay, so how can we decrease the volume of distribution for a drug here? One thing is plasma protein binding. Okay, anyone know any like particular plasma proteins we have? Never heard of albumin before? Albumin is the most predominant one we're going to be thinking about in terms of medications here, but albumin can bind to medications. So if a protein is binding up all your drug and keeping it in the bloodstream, what do you think it does to the volume of distribution? It's going to decrease it, right? Because now my concentration has gone up in that equation. You're going to find that decreases the volume of distribution. So more of it stays there in that central circulation. Conversely, say for instance I have a patient who is malnourished and they're not producing a lot of albumin themselves. What do you think that would do to the volume of distribution of that drug? Increase it, right? There's less protein to grab onto that drug and keep it in the blood. It distributes out. Okay. So these are things you have to consider. If I have a patient who's like emaciated, they're very malnourished, they're not producing a lot of albumin, that can affect the volume of distribution pretty drastically, okay? Dehydration can do this as well because, again, you're trying to keep your plasma volume up so that way you can perfuse the heart and the head. You may find that's also going to be decreasing volume of distribution. Things that can increase it, things like renal failure and liver failure. This causes a lot of fluid backup to occur, a lot of fluid retention, and that can lead to more water, and that can thus lead to more places for that drug to distribute out of the bloodstream, and that can also increase your volume of distribution. Okay, so it's not just fat tissue that goes into, but if you have a lot of extra interstitial fluid, say building up in the abdomen or elsewhere, you're going to find that it can also increase the volume of distribution. Okay, make sense? All right, fantastic. Any questions on the volume distribution topic, right? So again, this is very important to consider when thinking about, okay, how, if I modify certain components of this, how's that going to affect where drugs are going to be going to, right? And we'll talk about this, you know, kind of how it, once we all put it together a little bit later on as well, okay? Next we have metabolism. I'm wondering, probably don't really have time to cover metabolism in any great extent here. So let me check the board real quick. About halfway, a little less than halfway through, but that's okay. We'll make up for it. All right. Let me check the sticky board, and I got 2 questions so far. Let's see. Okay, so the first one, if Imodium is an opioid class drug and someone takes it chronically and then stops, could they get withdrawal symptoms or worsening of diarrhea? Yeah, so essentially if they're in, this is why we tell people not to take this chronically, or really it's a very like intermittent as you need it sort of drug there, because, you know, if I'm giving you a drug to slow down the GI tract for diarrhea, what is the flip side that's going to cause? Constipation, right? So we don't want to do that. It's a very classically known sort of opioid issue there. So potentially they could have rebound diarrhea. You can see that potentially. They don't really see a lot of the other withdrawal effects because most of that is mediated through stuff that's happening in the spinal cord and the brain. Because that drug never makes it there, you don't see a lot of that, right? So people don't really have don't really get addicted to it, so to speak. But you could see rebound diarrhea as a result of that, I think. Yeah, for sure. Okay, would drug test results differ if it was taken from the blood or the urine? Absolutely, yeah. So some things you may sometimes have to get like confirmatory testing from the blood. Usually for things like urine drug screens, you're just testing for the presence of it, so you can get the urine and that's fine. If I'm doing it for therapeutic purposes, like I want to actually see, do you have enough drug to get the right effect that I'm looking for? Or if they are presenting with toxicity and I want to make sure the level is not too high, that is something where the blood is really necessary because I need to actually see what is the actual tissue level, or the kind of what my estimated tissue level is based off of that blood level. Okay, so that's why that is more important when you're doing it clinically versus if you're just detecting the presence of it. So if you want to see if someone's smoking cocaine or something, then you can use the urine screen. That's fine. But if I needed to check the level of an antibiotic, the blood's going to be the thing I'm using there. Okay, make sense? Any other questions? Yes, sir.
What determines whether you have withdrawal factor?
A lot of things, man. A lot of things. A lot of factors. So, for instance, you know, certain medications the body just gets tolerant to, and it becomes, that's just the new normal, right? So if I'm taking oxycodone 20 milligrams 3 times a day, that's just the normal now, right? So when I take that away, the body craves that because it says like, wait a second, I'm outside of the normal. Homeostasis has been disrupted. So you can see withdrawal because of things like that. Other things could be, say for instance, I'm giving you an antihypertensive to lower high blood pressure. Remember, there's all that receptor regulation that occurs there, and I all of a sudden take it away. And blood pressure can go skyrocket back up due to that upregulation of those receptors there, right? So there's a lot of different features of it. Just because you say withdrawal doesn't necessarily mean they're having those cravings, they got to get the drug back, because most people, if I take them off their clonidine, they're not going to go scrounging for it, right, like they would heroin. But you can still see rebound phenomena. You can still see withdrawal effects. Antidepressants are another big one, where people who are taking it chronically, that is their new normal now, right? They're used to having that serotonin being at the levels that they're at. When you take that away, they get really bad withdrawal effects as well. They're not addicted to their SSRI, their Paxil, their Zoloft, but they need that effect around essentially. Yeah, so there you go. And we'll talk more about the specific examples a little bit later. I think you had a question?
Yeah, kind of off topic.
That's fine. I'm here as long as you guys are, so.
Like a 300-pound patient getting dialysis, it just makes it tougher.
It depends. So, you know, if you're thinking about things that you're pulling off in dialysis, it's mostly going to be more, it's stuff that will be going through the kidneys anyway, right? And when we get into elimination, we'll talk about things being more water soluble or easier to get rid of. So in those cases there, you're getting rid of waste products, you're getting rid of electrolytes. It's going to be a little bit easier to do that because most of that stuff is water soluble anyway. So it has less of an effect there for those patients. Yeah. Yes, ma'am.
So when testing for lipophilic substances, will the concentration be stronger in urine versus blood?
You normally are not.
Like due to the marijuana.
Yeah, so normally you don't test for like blood levels of marijuana, right? So I guess you could technically, but there should be an equilibrium between the urine level to the plasma level. I can't say whether or not one would be higher necessarily than the other. It just depends on how things get concentrated or not. It gets more complicated in terms of like renal physiology with it reabsorbing or secreting things, but clinically it wouldn't really matter so much in that case there. But and again, we're never measuring like tissue levels. Like I'm not going to take like a fat sample and see what it is there, but because I have the urine, right, I can just do that. It's much easier to do in those cases.
So it's just more of like even access versus differences in concentration.
Yeah, so if you're just going for a drug screen, or if you're going to go for a new job, do you necessarily want to get a blood stick, like, or get a venous stick? Probably not, right? Versus if I can just give you a sample of urine, you're totally fine there. I remember one time I was going for a urine drug screen for a job, and I came out and I said, "Is it weird if it's purple?" And the lady got very, very concerned. And I said, "I'm just kidding. It's normal color." But don't mess with those people because they don't like that. They're really all serious. Anyway, other question, sir.
Back to like the addictive thing. So let's say you take like milligrams of Xanax every night. What is it called like when you try to like reduce that dose so you don't become tolerant to do it?
Yeah, so it's called weaning, right? So you wean off the dose because otherwise you get rebound insomnia, right? A lot of drugs you're going to see, if you're using it to treat something, a lot of times you're going to have the rebound effects when you withdraw that drug abruptly. So for instance, if you're taking Xanax every single night to go to sleep and then you say to run out of your prescription, then all of a sudden you're going to have a hard time getting to sleep because you're used to having that drug around to kind of get you more sedate.
Is that what you do when you decrease the dose gradually for the steroid?
Yeah, so if you were to see like a steroid, so we'll talk more about that in details on why we do that, but yeah, so if you were to gradually taper a dose, that's called weaning, and that helps to get the body back to homeostasis, kind of the normal drug-free state, a little bit easier there. Okay, I'm going to post up the next homework assignment, check your syllabus to see when that's going to be due. I don't remember off the top of my head. And everyone's assignment has already been graded, so good job on that. Everything looked pretty good for the most part. If you have any comments, I made those where appropriate. And otherwise, I'll see you guys next time.
Thank you.
Have a happy 4th of July. Don't eat.